should understand the thyroid gland, and I'm not going to detail, but just to recap what all is there. So there is, there is a hyoid bone, then thyroid cartilage, and then just underneath that lies the isthmus of the thyroid gland. And on the both sides are the two lobes of thyroid. So it's very prominently known as a shield-like organ, which is right in front of our neck. So that that any swelling in this part of neck is considered to be thyroid unless proven otherwise. So very frank, if there is any swelling in the front of neck, the first thing we should think about is thyroid. Just a side anatomy, what I want you to focus here is this is the area of thyroid gland, and see if when it enlarges, it can come to lie in this space, which is there's the aorta or the vessels and other things entering here. And then on the front is the manubrium sterni. So this space between the vertebra and on the sides will be the first ribs, is the thoracic inlet. And if this thyroid gland enlarges and occupies this space, it can start compressing on the structures which are either entering the thorax or leaving the thorax, mainly the veins, because they are easily compressible. So it causes compression on the veins and then causes symptom. We'll be talking about this. Vascular anatomy, we'll talk whenever it's in. I just want it to be there as an image in your head so that you understand what is happening and what. So focus on this point. The thyroid is very tightly attached to the larynx, and which moves in deglutition. So that's what causes thyroid also to move. There's also something you can see as a pyramidal lobe, which as an embryological remnant, it attaches to the tongue or the base of tongue through something called as a Thyroglossal duct or tract. And in most of us, I think this gets obliterated and disappears. But in some cases, it can sting called as Thyroglossal cyst. And because of this relation, it will move with protrusion of tongue also. So that is important entity. And now, then also it's very closely related to parathyroids. And this is the inferior thyroid artery. Now also look, this will be important when we'll talk about the signs, that the inferior thyroid artery is deep behind the thyroid gland. So from anterior, it is by no way you can approach this inferior thyroid artery. This is an important surgical landmark, and it has a relevance in some of the signs which we'll be talking about. So overall, neck swelling can either be thyroid and maybe some other swelling in the neck, but mostly the midline swellings we talk about thyroid. And if it is thyroid, then it can be either solitary, it can be multinodular, or it can be smooth. Okay, so smooth means the whole gland is enlarged without causing any nodularity or anything, or there can be one nodule on any of the lobe, or it can be the multiple nodules either in one lobe or in both the lobes. So this is how we clinically define any thyroid swelling. So you just define that whether it's smooth and which we call a diffuse enlargement of thyroid, or it is multinodular, or it's solitary thyroid nodule. If it's a solitary, then which lobe it is, it has to be defined. Also, we need to find out the functional status, whether the patient is euthyroid, hypothyroid, or hyperthyroid. We have to kind of have some idea about whether it's benign or malignant, and whether it is causing some local pressure effects or not. These are the main questions which we start with whenever we examine a thyroid case. So again, at the end, you should know that you are answering all these questions. Again, I'm reminding, I keep on telling this, whenever we make a diagnosis, we tell 5 things. So we tell the anatomy. So here it's very easy. If it is thyroid, it's thyroid. But we have to also specify which lobe it is, whether it's median isthmus is involved or not. The second thing is we talk about the pathology. So after anatomy, we talk about pathology, whether it's multinodular, nodular, and all these counts as a pathology. If you can talk about malignancy or not, if you can talk about what kind of goiter it is, well and good. Whatever details you can tell about the pathology. After pathology, we need to talk about etiology. It is iodine dependent, it is malignant, what mutations, familial, whatever. So it has to be, we have to find out that through our history and examination. Then comes the stage of disease, means how large is the swelling, whether there's a local pressure effect or not, whether it has metastasized to other areas or not, whether there are lymph node involvements or not. And the last point is effect on patient. So all 4 or 5 points, if you have got the answers to all the 5 things, I think your diagnosis is there. And then you can start talking about the management of the patient. So as in any case, in this case also, you have to keep answering this, and you see that that's what we have talked about. So in history, we take first history, we talk about mainly the neck swelling. I'll not go into various details because there are a lot of things in examination. So we talk about neck swellings, what's the duration, how is the progression, whether there's any fast, rapid growth, which suggests maybe malignancy. The sudden increase in size is malignancy. Whether there are any pressure symptoms, which can be direct pressure on esophagus, on the trachea, leading to dysphagia and dyspnea. It can also involve the recurrent laryngeal nerve or other external laryngeal nerve to cause hoarseness and sometimes stridor as well in severe cases. So this is what it is. Also, you talk about functional symptoms. We talk about hyperthyroidism, which is suggested by, now it's easy to understand. All the symptoms which are caused by high adrenaline state are all by hyperthyroidism. Because we all know that what thyroid hormone does is it upregulates ADR receptors expression in cells. So basically, for the same level of adrenaline hormone or in body, the cells are not responding at a higher level. So all the hyperthyroid symptoms will be as same as high adrenaline status symptoms. Whereas on the other side, hypothyroidism is again the kind of opposite of ADR receptors, because the ADR are less expression, the expression of ADR receptors on cells is less. So it will present with weight loss because of weight loss, because of high BMR, palpitations because of the effect on heart, tremors because of the effect on the neuromuscular junctions, heat intolerance, again, because of the high body metabolic rate, anxiety, again, you can relate to hyperthyroid and high adrenaline status. Whereas in hypothyroidism, there's the opposite of it. Patient feels lethargic, there's a weight gain, and there is cold intolerance. So very easy to understand, but take history of it. Now, we know that there are some endemic areas where goiter is common. Now, this effect is day per day is going less because of the availability of iodized salt, which is available almost across in the country. But there was one time when it was a very kind of a social symptom, social status, that, I have this big swelling. Somebody is not having a swelling, they were considered as abnormal. That was a time in Himalayas that people were very proud of their neck swellings, and later did they realize that this is a disease. So this is what endemicity does. Also, along with endemicity, we ask for if there is any radiation exposure in childhood, so that it can also lead to expression of some malignant disorders in this. So we ask the history of cranial radiation, ask history of some family history of familial thyroid cancers, some thyroid diseases or other endocrine diseases in family, and other neck swellings in patients. So rather overall, we ask whether there is any malignancy history or any surgery which was done in the family. And be careful in cases of ladies, do talk about their family. Sometimes when you ask about their family, they start talking about the husband's family. So it is important that you take history of their maternal side.